First of all, I'd like to thank the Regenix and their team for inviting me to present this session. In the management of diabetes, we face a lot of challenges, particularly in prescribing insulin. It's a task for every diabetologist and physician as well as the endocrinologist. So we always try to tailor the regimen, fit into the patient quality, routine activity, so that their quality of life is improved. So one such thing is this Insulin Glargine. Insulin Glargine is not a new one, but it has been introduced so many years together. But now they have a particular company has developed this particular brand. And also Insulin Glargine, of course, it is one of the important insulin analog, I have to say, undergone extensive trial in the real world study. So today's topic is on how to use this Insulin Glargine in our practice and where to fit it. So without wasting much time, we'll go into the slides. So the unmet gap in diabetes care. As you know, the diabetes, 72.9 million Indians have diabetes. So we rank second in not only in population but also in the diabetes prevalence, and very soon I hope we overtake China. And our Asian phenotype has got a typical characteristic of diabetic manifestation when compared to the Western population. So the diabetes is the younger onset, high insulin resistant, and there's a rapid decline in beta cell failure, rapid decline in failure function, so that very soon they need insulin therapy. Apart from this, we have a high risk of cardiovascular complication because most of 30 to 40% of the patient does not achieve the target of 7 HbA1c. So we need to intervene at a particular time, so that early initiation of insulin therapy for those patients who needs it definitely is going to bring down the both micro as well as macrovascular complication in diabetes. There is inertia in initiating the insulin therapy because 73% of the patient, they fear of not the insulin but the prick pain. So they have a psychological obstacle, so that there's a delay in. And apart from this, 48 when the patient accepts insulin, the 48% of the people who accept the insulin therapy, they discontinue 3 months because of confusing titration and complex regimen and so on and so forth. So we need to use the insulin. We need to convince the patient and give a simple regimen so that they have a more adherence and to the insulin therapy, and the compliance will be good. So it's our responsibility to make it happen. So we have this Insulin Glargine, which is going to be the basal backbone in the therapy of type 2 diabetes as well as type 1 diabetes. So this particular molecule, we call it as insulin analog, a specific structure, pharmacological structure, which makes the insulin a peakless insulin, and 24 hours basal insulin level is maintained. So this control of blood sugar is continuous, predictable, and there is a physiological smoothness there. So if you take the structure, of course, insulin, everyone know we have a 2 chains, A chain and a B chain, and A chain made of 21 amino acids and B chain made of 30 to 36 amino acids. And this in A chain, there is a substitution of asparagine glycine. So this prevents the acid degradation of the insulin when injected into the subcutaneous tissue. If we take the B chain, there is addition of arginine, those are amino acids, addition of arginine in B31 and B32 position. So this makes it as an isoelectric shift to isoelectric point. This enable the insulin to crystallize the subcutaneous tissue so that they release insulin very slowly. So when we inject step 1, if we inject the insulin at the pH of 4, that is an acidic, soluble insulin is injected in subcutaneous tissue at a pH of 4, that is an acidic way, so that it did not get degraded. So once they get injected, they get neutralized and there's a depot formation. So this form microcrystals in subcutaneous tissue so that the insulin is released very slowly. So there is a half-life of the insulin is prolonged, say about 15 hours. So if you take this pharmacokinetic of the particular insulin, pH 4, already mentioned, it going to precipitate upon neutralization in subcutaneous tissue at slow and sustained release 24 hours. The half-life is approximately 12 hours, but it may vary with the patient roughly around up to 12 to 15%. So and the action is, if you could see the graph compared to the NPH, there's always a peak. So here you have the Glargine, which is a peak-like insulin, and the the pattern of work is highly continuous and predictable over time. So we have the scientifically designed insulin analog Glargine. It has got so many clinical benefits. So if we take the Diamond Registry, the Diamond Registry of 2025, that is called Diamond Registry. So we have this particular insulin Glargine when compared to NPH. When they switched from NPH, when those patients already receiving NPH switched to Glargine, there is a 28% fewer nocturnal hypoglycemic events tracked by continuous glucose monitoring system. So always when you choose the insulin therapy, the main fear of the patient is number one, needle, number two, the fear of hypoglycemia. So the if patient experience one episode of hypoglycemia, definitely the compliance to insulin therapy is going to come down drastically. So here we have this particular Glargine compared to NPH, that's a 28% decrease in nocturnal hypoglycemia. This is very worst thing happened in insulin therapy. So apart from this, since it has got a flat profile, not only nocturnal but also daytime hypoglycemia is very less with the Glargine when compared to the traditional NPH insulin. Apart from this, if you take the safety of the insulin, when compared to the insulin detrimer, this is not inferior in the MACE study. So it has been very proved to be safe in cardiac outcomes. Apart from this, there is a decrease in 12% of the patient with the hospitalization due to heart failure. So these 2 points make this Glargine a safer insulin when compared to the other insulin or other base analogs available in the market. Apart from this, the more important is the weight gain you see with the insulin. So most of the insulin, they produce weight gain. So here you could see the usage of Glargine produce only 0.3 kilogram of body weight increase. Whereas if we usage is pre-insulin, there is a 1.8 kilogram increase in the real world study, the real Glargine study. So this clearly shows the weight is minimal or almost weight neutral when compared to the other insulin. So this insulin is weight neutral. There is a low incidence of hypoglycemia, both daytime as well as nocturnal. And also there is good study for the cardiovascular safety. So all these things add up to the benefit of using this Glargine in our diabetic patients. So already we discussed from spikes to steady. So the NPH, you have a peak as well as the trough. Here there is a peakless insulin, always a latch. You don't have this particular peaks, so there's less incidence of hypoglycemia. So how to start the Glargine insulin, the practical book. So who are all the patients that is going to be benefited the immediate initiation of this particular Glargine? So those patients having HbA1c of more than 9 or fasting glucose more than 130 despite more than 2 oral anti-diabetic agent at the maximum tolerated dose. Number 2, that's the clinical inertia. No intensification of therapy for more than 12 months despite the above target glucose. So these two types of patient are the immediate candidate where you need to initiate with insulin Glargine therapy. So always you start with the low dose, say about 0.15 units per kilogram body weight per day, so maximum of 10 units per day, than 130. And if there is, you should keep a range of 80 to 130. If it is less than 80, then you have to decrease by 2 units. So always preferable side is abdomen. Rotate the side by 2 inches. 1 inches. So this is a titration algorithm from day 0 to goal. So our goal is to achieve HbA1c of 7 and the fasting blood sugar between 80 to 130. So either you can do a continuous glucose monitoring system, is very well available in the market. We have so many brands coming to the market. Or you can do a 7-point SMB, self-monitoring blood glucose, the patient can do by themselves. Say a fasting PP and pre-lunch, post-lunch, pre-dinner and bedtime. So on and so forth. So this already I mentioned, if the blood sugar is less than 80, you have to reduce by 2 units, and if the 3 consecutive low, you have to hold for 48 hours and reassess the patient. So if the blood sugar is between 80 to 130, then you maintain the dose. If the blood sugar, fasting blood sugar is more than 130, you increase 2 units every 3 days. So to confirm the stability, you need a 7-point SMBG or glucose monitoring, and this titration should be done within 3 to 6 weeks of initiation. So that's how we go with the starting the insulin therapy, and also to titrate it and to maintain it. So now we go on to the cases. So we will see a few cases, a few scenarios where this insulin is going to fit and the patient is going to get the maximum benefit. Number one is the overweight patient. He's 58 years old male, and you see his basal HbA1c is 9.8 and BMI is around 32. And the patient is on metformin 1000 milligram twice daily, and there is no prior insulin experience. Now, a patient is initiated with the Glargine 10 units at bedtime and titrated up to 22 units over 4 weeks using the 2 unit every 3 days protocol, as we discussed in the previous slides. Then at 12 weeks outcome, able to see there is a reduction in blood sugar HbA1c to 7.2, that is around 2.6% is clinically reduction. This is again a statistically significant value should be. And apart from this, there is zero nocturnal hypoglycemic episodes during titration as well as the follow-up. So now we can clearly see there is a rapid reduction and very good reduction of HbA1c when you initiate the. Then the elderly patient with chronic kidney disease stage 3. Those days when NPH is only available as a basal insulin, the nephrologist won't touch the basal insulin. They always rely upon multiple pricks of short-acting insulin for fear of hypoglycemia. As everyone knows, the insulin is metabolized in kidneys. So when using this long-acting insulin will prolong the half-life and patient will go for nocturnal hypoglycemia. But now with the advent of the Glargine, even those patients having a chronic kidney disease, we can use it. So here a 73-year-old patient, GFR is 38 ml, where the patient is on chronic kidney disease stage 3 and the baseline HbA1c of 8.4 and sulfonylurea was felt due to hypoglycemic risk. And now this patient was started in 8 units of Glargine in the morning and conservative lower dose because I already told because of the high incidence of hyperglycemia, renal failure. So 6 weeks outcome. Again, the strategy was followed. The 2 units every 3 days strategy was followed. And at the end of 6 weeks, there is a 0.9% reduction of HbA1c is safely achieved without an aggressive titration. So no hypoglycemia, renal function remains stable throughout the follow-up. This clearly showed even it can be used in special situations like patients having a chronic kidney disease. Then adolescent with type 2 is becoming very common nowadays. Even the school going, college going people, they have a type 2 diabetes, not type 1. So here is a patient with 16-year-old type 2 diabetes with the BMI as higher side and the obese range. So HbA1c is 9.2 and the challenges the school schedules and social stigma. So again, Glargine, since the body weight is very high, you can start with 0.2 units per kg at bedtime with tailored education for school time dosing and discrete administration. So 3 months follow-up again with a rapid around this 2 unit 3 days regimen titration. HbA1c came down to 7.8. There is a 1.4 reduction of HbA1c and the regimen was well tolerated. The patient lifestyle was so good. So that is already mentioned the quality of life which we see in any regimen, particularly the insulin. So there's no incidence of hypoglycemia and the patient reported increased confidence. So this again shows even with the adolescent type 2 diabetes, the Glargine is a drug of choice in management of diabetes. Then the switching strategy, how to switch between the insulin. So those patients already having the NPH, you can switch to Glargine. So what we do is you calculate the dose by 80% because, by example, the patient is receiving 50 units per day. So you can go up to 40 units per day. So example I am telling. So you decrease by 20 units and you maintain the other oral agents and discontinue sulfonylurea if there is oral hypoglycemia risk. Educate on abdominal injection and site with timely consistency. And apart from this, again, we have to adjust the dose and gradually there will be you can achieve the HbA1c with this Glargine. So if you go, another important point is there is a 38% reduction in nocturnal hypoglycemia and also the dose requirement will be less than 20% than the NPH. So Glargine requires a lower dose than the NPH for glycemic control. This is another important point. So apart from this, if you need a basal insulin, of course they control only the fasting. So what about the postprandial? So postprandial control is also important for HbA1c reduction because both of them they play important role in HbA1c reduction. If we feel if the patient has a postprandial peaks, you can add a rapid acting insulin. So definitely with this mixture of basal only plus rapid acting, you can have a better control of both fasting as well as the postprandial hyperglycemia when compared to the pre-mix 70/30. So this transition required a patient education and the dose adjustment between this basal and rapid acting insulins. So tailoring to the basal insulin in special population, particularly elderly and renal impairment. So both of them, they need a meticulous care. Elderly, they go for hypoglycemia because of lack of care and so many factors. Renal impairment, the drug, the pharmacokinetics of the drug is altered because the insulin is already, I told you, is metabolized in kidneys. So always start with the low dose, say 0.1 units per kg. Consider glargine to minimize injection volume and peak related risk. And you have to monitor the GFR every 3 months. Anticipate a progressive decrease in insulin requirement as the GFR drops below 30 ml per minute. And particularly avoid the concomitant sulfonylureas. And there is an hypoglycemic risk in these populations. So prioritize the DPP4 receptor inhibitors for residual glycemic control as a safer combination partners. So it's very important. You can use the DPP4 inhibitor along with the basal insulin for these two special populations, the elderly and the renal population, renal impairment. And last but not the least is the approval for pregnancy. Of course, this one drug which has been proved to be very safe in pregnancy, and it has been approved by US FDA in 2022 for use in gestational diabetes. So you can use this as well as the aspart, and this glargine has been approved and safe and effective in pregnancy. And in children less than 2 years, you can start at 0.2 units per kg, but titrate cautiously and monitor the growth related sensitivity shifts. So as the patient grows, you need more amount of insulin because of rapid growth in children. So, and also there is a change in the insulin sensitivity as they grow. So we need a frequent dose adjustment. A close monitoring is required in the pediatric population. But both situation you can use this glargine very well. Injection technique, you have a 5 golden rule. A needle and angle, use 4 mm needle, insert at 90 degree, and side rotation more than 1 inches. And always prime the pen with 1 to 2 units so that you don't have a difference in units used. Stored in 2 to 8 degrees centigrade. And document every dose to enable provided review and pattern analysis. These are the 5 golden rules of injection technique. Then we are going to bridge the gap today. Call into action, audit the practice. Those patients who require basal, that is HbA1c more than 9, initiate the therapy and switch to eligible patients. So those patients who are already on other biosimilars or NPH, shift to glargine and equip with the smart pen. All the patients who need initiate with the insulin glargine, educate them, and you measure the hypoglycemia as well as the 5-step titration protocol, and also the target for reduction in hypoglycemia rates by within 6 months, and commit to the mission. Closing the diabetes care gap happens 1 basal dose and 1 patient at a time. So this is a motto of our presentation today. So we have bridged the gap today. So they have this particular brand is available in the market now, and they have done a study as well, and they have found out it's very effective in both type 1 as well as type 2 diabetic patients. When decreasing HbA1c, fasting blood sugar, postprandial blood sugar, and the immunogenicity is also very low. So insulin allergy is not seen with insulin glargine. And pharmacokinetically, it is also similar to the gold standard analogs, and also not inferior to the other insulin, decreasing the various parameters. And it also already we have seen it is cardiac safe. So we need to initiate this insulin glargine for those patients who deserve it, and we can see the better result, which we have been using since it launched.